So I wanted to do something. And so this kind of came from a poll, asked people what they wanted to learn. They said stuff about the low back, stuff about movement. And so I just kind of merged them. Low back pain is like a special topic for me because I've had low back pain, really, really bad low back pain that ended in surgery. And so I really like to talk about low back stuff. Also, it's one of the things that I think we deal with the most as healthcare practitioners, and is a problem that almost everyone will experience at some point in their life. So let's start to look at this stuff. This is just going to be short. Probably we're on here for maybe 20 minutes, half hour. But in that time, I just want to talk a little bit about the mechanisms and anatomy related to the experience of low back pain, how to recognize some red flags. And I'm going to go through 3 movement drills that address the mechanism and anatomy of low back pain, and that link some of what the low back really needs, or the needs of people with low back pain in kind of a paired type of movement drill. So there's 3 movement drills, but they're kind of a few drills in each, or at least one with multiple drills. So let's start to take a look at this. If you have questions for me, certainly ask throughout. I'm fine with that. Know that right now I'm just spotlighting my video, and that's what will show up in the recording. But if you unmute yourself, you might show up. So if that's an issue for you, certainly use the chat function. So the reason why people have low back pain is actually not really well understood. So there's not a ton of reliable information about why people experience low back pain, some of the factors involved. Some of the factors that are involved in one person experiencing low back pain are not the factors involved in somebody else. We probably all have seen the stats about MRIs and imaging and how unreliable they are as markers of whether or not somebody's going to experience low back pain. So most people of varying age ranges will have MRIs that look terrible and not have pain associated with them. So we don't have a ton of reliable information about what low back pain is and what causes it. There are some theories that some people like to attach to, and that's fine. And some of those include poor coordination or motor control issues. So not so much that something is not firing, but rather the timing of a series of events or series of muscle contraction is kind of off. Generally speaking, when we think about movement, we start with the deep structures that provide a stability and a foundation first, and then the larger muscles begin to contract, for lack of a better term, a little later on. And I don't mean minutes later, milliseconds later, but that coordination can bring up issues associated with pain. Presence of scar or soft tissue changes that affect sensory input. So if there's scarring present kind of anywhere, especially in the trunk, that presence of scar tissue can impact some of those sensory nerves a little bit. And sensory nerves are kind of like a touch plate, right? Like in the Olympics, in Olympic swimming, right? When you touch the touch plate and it marks that you're done. That's kind of what sensory receptors are like. So they respond to some type of sensation, deep pressure, light pressure, vibration. And the presence of a scar can increase afference or sensory information along those receptors or along those nerves that make the body think something is happening that is not happening, or make the nervous system or brain think that we're in a different position than we really are. And that can affect motor control, that can affect coordination, and that can create the experience of pain. Trauma and perceived threat. So both real and perceived threat can also be a source of low back pain. Here is some of the anatomy associated with the low back. It's not all QL. So let me play this. I'm hoping that this is going to be quiet. Yeah. So this is the anatomy of the low back. A lot of the times when we talk about low back pain, we talk about QL. People talk about QL a lot, and there's way more happening in the low back than just QL. And so here you can see just kind of unraveling different layers of muscle associated with the low back. So we definitely have QL, and QL is going to be the last to appear here. But we also have transversus abdominis, that deep abdominal muscle. We have internal oblique, IAO. The internal abdominal oblique has attachments posteriorly, and certainly that can be involved in low back pain, especially when the low back pain is kind of just around this SI joint or above this SI joint, the area that people mostly call QL. This actually, and you can see here, is the attachment point for internal abdominal oblique. And so that can be hugely implicated in low back pain. Multifidi play a role in making sure the intervertebral discs kind of stay where they're supposed to be, or controlling intersegmental movement of the spine. And when multifidi are inhibited, or there's a lack of coordination, blah, 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 we can also experience low back pain, mostly because of the erector spinae, which create a global extension and can create compression of the spinal segment. So all of that extension intolerant low back pain can be a relationship between multifidi and erector spinae. And then we also have lats back there. So big, huge lats attaching to the thoracolumbar fascia. And we know that the thoracolumbar fascia definitely has been investigated quite a bit with ultrasound. And the finding there is that in all people, in these studies anyway, that had the experience of low back pain, the thoracolumbar fascia didn't glide appropriately with surrounding structures. And so that seems to be implicated heavily in low back pain, way more than posture, way more than MRI findings even. And so we can look at some of these other muscles and their relationship to the thoracolumbar fascia and learn a little bit more about what really might be involved in low back pain. QL doesn't really, it doesn't really make a significant attachment to the thoracolumbar fascia, but what does is transversus abdominis, internal oblique, multifidi. Lats and erector spinae make attachments in the more middle and superficial layers of thoracolumbar fascia rather than the deep. And so anything that really affects the thoracolumbar fascia can be implicated in the experience of back pain. Posterior SI ligaments, the iliolumbar ligaments, also have referral into and around the low back and SI joints. So absolutely can be implicated in low back pain. Ligamentous trauma from birth, ligamentous trauma from accidents or falls, all can lead to referral that causes the experience of low back pain. And then we, of course, have SI joint compression, intervertebral joint, and zygapophyseal or facet joint compression that can cause referral and that can cause low back pain. So facet joint compression or zygapophyseal joint compression happening in the lumbar spine associated with extension or lordosis. SI joint compression associated mostly with anterior pelvic tilt, all can happen and contribute to the experience of low back pain. So here are some red flags associated with back pain, specifically low back pain. We have to rule out viscera, so it could be an organ. The kidney refers across the low back and the SI joint and the lateral thighs. Also, bladder refers to the sacrum. The liver and gallbladder refer to the right posterior lower ribs, so they can kind of be in the mix there. But definitely organ referral can mimic some low back pain. And we want to make sure that there's no other parts of the history that tell us that maybe there's something going on with kidney, maybe there's something going on with bladder, liver, or gallbladder. It could also be, low back pain also comes from trauma to the aorta or a change in the aorta, specifically aortic aneurysm. So an aortic aneurysm will often not have a mechanism of injury. The symptoms associated with an aortic aneurysm are low back pain, but low back pain where there's no aggravating factor and nothing that makes it better. And then also the presence of a strong, non-painful midline pulse over the abdomen. So in the case of an abdominal aortic aneurysm, there's a very palpable, strong pulse over the middle of the abdomen. And so those are some signals that there's something bigger going on than just low back pain. And then, of course, cauda equina syndrome. Cauda equina syndrome is associated with compression of the lower end of the nerves that exit the spinal cord. So spinal cord ends at about the level of L1, L2, and then the rest of the spinal nerves continue as a cauda equina or a horse's tail and enter the lower limbs. And that cauda equina can be compressed by a disc or some other space occupying lesion. And in that case, there are significant bowel and bladder symptoms. Either there's retained urine or feces, or incontinence. People will often also experience saddle area sensory changes. So sensory changes around like the perineum, the genitals, external genitalia, also the feet and heels. Experiencing sensory changes, numbness, tingling there can be an indication of cauda equina syndrome. And this is a medical emergency. The aortic aneurysm is a medical emergency as well. And really, I would think that anything related to the aorta or compression of the cauda would be a situation where you would tell people to leave because both are medical emergencies. So these are red flags that you might want to factor in if you're looking at people with low back pain. So let's take a look at how we can introduce movement to improve function of the low back. So these 3 drills I will often use to help take down symptoms, but also to help build on really what the low back is looking for in terms of what it's looking for really healthy function. So the first is a breath drill. The second is addressing the thoracolumbar fascia, and then linking intrinsic core control to hip movement. So let's take a look at those. This is basically one of my favorite breathing drills. So a 360 breathing drill is done by creating puff 360 degrees around the trunk. On my YouTube channel, there's quite a bit of discussion about a 360 breathing drill, so you can find it there. This position, doing it in prone, helps to facilitate eccentric load of the posterior abdominal wall and multifidi. So when you place a pillow at the abdomen and lie prone, what you're doing is you're taking away lumbar lordosis. So this is especially great for those extension intolerant people that have like facet joint compression around the lumbar spine and symptoms of that. So the pillow there provides for a little bit more relative flexion in the lumbar spine. And then when you breathe, the abdomen moves into the pillow and is limited. So you can't really expand very much in the abdomen. And what has to happen is you get movement here in the low back. And what's happening is as you breathe, the organs are pushing into the anterior vertebral bodies, and they're creating a flexion moment in the lumbar spine. And when you create flexion in the lumbar spine, you initiate a spinal reflex, the stretch reflex, that causes the extensors, including multifidi, to have to contract. So it's a spinal reflex. This is a really nice, gentle way to get some of those deep core muscles supporting the lumbar spine a little bit better. It also creates eccentric load and expansion through some of those tissues like the lat or the erector spinae that might be kind of locked short. This position will also create a little bit of stretch through the thoracolumbar fascia, which also can improve glide and decrease symptoms. This position and this drill is particularly great for people that have a history of disc issues associated with low back pain because it really does target the multifidi. It's also really great for people that have very acute pain and really can't do any other drill. This is a nice gentle drill for people to do who are experiencing pain. Certainly doesn't have to happen on the floor, can happen in bed or on a couch or whatever other surface, as long as there's enough blocking for the abdomen that you can get this puff in the low back. So that's 360 breathing in prone, very, very accessible for most people. The head is stacked on the hands. You can either stack the fists, depending on how much elevation people need, but the neck should be in neutral. So the chin tucked and the center of the forehead resting on either a pillow, a block, or your stacked hands. Cool. All right, let me go to this next one. This next one addresses the thoracolumbar fascia. So we know that the thoracolumbar fascia needs to be able to glide. Really important that the thoracolumbar fascia can glide in order to reduce symptoms of low back pain. The thoracolumbar fascia, though, often is restricted because it's making up for something else, whether that's a loss of control in the intrinsic core, or whether or not that is because of some larger muscles like the lats or the glutes kind of not pulling their weight. Whatever reason the thoracolumbar fascia is restricted or tight, we need to pair the release of the thoracolumbar fascia with introducing a little bit of strength and stability, just so that we're not leaving people with no strategy. We're not leaving people vulnerable. So in this drill, we're addressing the thoracolumbar fascia. Here I'm using this band, just a TheraBand, but actually this is not the best tool to use. You should look for those thicker bands that are often used to assist pull-ups. So those thicker bands that basically look exactly the same, except they're thicker in width. And you typically hang them from like a pull-up bar and stick your foot in it to do assisted pull-ups. That's the kind of band that you want. Or if anybody has done dermoneuromodulation, they use something more like this TheraBand that doesn't create glide along the tissue. That can work really well. I just like a thicker band because it tends not to fold over. So when I show you this video, you'll see that it's folding over on itself. It might have been better if it was directly on my skin, but I wasn't going to be topless for you here. So this band is actually used to make contact with thoracolumbar fascia and then create drag, just like you would do fascial techniques, right? So we wouldn't do a fascial technique by running the fingers along the tissue. We would engage the tissue and then move the tissue, the superficial tissue relative to the deep tissue. This is the same thing that's being created here. So I'm holding it kind of like a towel, but you can also loop it over like a doorway or a doorknob and kind of sit inside of it if you didn't want to hold it yourself. So let me show you how this works. You're going to place the band across the thoracolumbar fascia. It's not going to be folded over like that because it's going to be right along the skin. And then you can tug it left, right. You can tug it up, down, kind of in diagonals. Really what you're doing is you're trying to assist or you're trying to achieve self-myofascial release. So however you do that, that's why I do like the thicker band, though. You tend to get a little bit better drag with a thicker band. And so you spend a little bit of time mobilizing the thoracolumbar fascia so that you improve mobility there and take away some of the restriction, maybe the restriction that has built up there because the low back is looking for some support. And then I'll typically pair this with kind of like a Superman drill. I call it Superwoman because it's done a little bit differently to help increase activation of some of those extensor muscles, again, like multifidi. You can also pair this thoracolumbar fascia drag with a breathing drill, with a dead bug drill, with any other core drill you want. So here's how you set it up. You're lying face down. The head is right on the floor. Your hands are by your shoulders. And what you're going to do is you're going to imagine dragging yourself through your hands so that you lock down the lats before you lift up into extension. And so what that does is it helps to lock down some of those big prime movers. So the tendency, or what we're trying to achieve, is a little bit more activation using some of the small guys like multifidi. And so I'll just show you. I'm dragging myself through and then lifting while my elbows are dragging down towards my glutes. Yeah. And I would do that several times. So I'm dragging myself through first and then lifting. This drill, again, you can pair a thoracolumbar fascia drag with anything. The thoracolumbar fascia is heavily implicated in low back pain. And as long as we're pairing it with a drill to introduce stability or to introduce strength, then we're going to get a good result. Releasing the thoracolumbar fascia without pairing it with something that introduces stability or strength is usually where we kind of go wrong. The thoracolumbar fascia especially is doing a ton of work in low back pain patients to create stability. And when we remove it without adding anything in, we often get kickback pain or just not really great results. So let me show you this last drill. This is the quadruped squat and the goblet squat. So again, you could do this thoracolumbar fascia drill and then do this. So one of the other really big problems with low back pain people is that people that have low back pain often have a loss of intrinsic core control. So that deep core is not working so well, or the timing is a little off. And what will often happen there is that the hips tighten up. So this is a model or a concept that was kind of popularized by Gray Cook. And it's often referred to as the joint by joint approach, where some joints tend towards more stability while others tend towards more mobility. And the hip joint is a mobile joint. It is a ball and socket joint. So the structure alone tells us that that joint is designed to be super, super mobile. But when we don't have a really good foundation, so when there are core issues, low back pain, there's not that stability happening around the trunk, around the lumbar spine, and the hips can lock up in attempts to prevent us from injuring ourselves, right? We can't have the super mobile joint right next to a joint that is also super mobile. The way that we're kind of set up as humans is that our joints are stacked so that one is mobile, one is stable. Next one's mobile, next one's stable. So that two really mobile joints, naturally mobile joints, aren't paired next to each other, because then they don't have the stability to really function in a healthy manner. So this is what happens when we see people who have tight hips and low back pain. The tightness in the hips is a protective function. So we don't want to remove the tightness in the hips alone. We want to pair that removal or pair mobility of the hips with core control or activation of the deep core, never alone. And so we can do that by using the quadruped squat or the goblet squat. So when we pair hip mobility with trunk stability, this exactly addresses that joint by joint approach. You're giving the body the stability it needs to allow the hips to be mobile, rather than forcing the hips to be mobile without giving them the support. If the reason why the hips tighten up is because they don't have a stable foundation, then just forcing them to be long and loose and mobile is not going to help for very long if they don't have a stable base. So these two options I've given because one is a little bit more accessible to some people, maybe safer, and the other may be a little bit more challenging. Just because you're on 2 feet rather than on hands and knees doesn't mean it's more challenging. There's lots of factors that play a role, but these are two options for how you can pair trunk stability with hip mobility. So in this quadruped squat, you're doing exactly what it sounds like. You're on all fours, so that's quadruped, and you're mimicking a squat pattern. But what you're doing is you're maintaining a nice solid trunk. So we're doing this for back pain patients, not for just regular people, right? And so the neck is long, chin is tucked, the ribs are tucked, and the sternum is lifted. So you're not caving in, but you're not in extension. And the feeling is that every time you can pair this with inhale, exhale, doesn't really matter. You can inhale to lower, exhale to come out, or vice versa. You should be able to do both. But this is what it looks like. So my trunk is staying stable. I'm not creating flexion here or extension. And what I'm saying to my body is, hey, you've got a really strong trunk. Allow my hips to be mobile. Every time I drop back, I can shift the position of my knees, widening them or narrowing them to have different effects on different muscles around the hips. So I'm saying, I'm giving you core support like you want. Allow my hips to be mobile. The same thing is going to happen in the goblet squat, which is coming next. So in the goblet squat, you're widening your legs as far as you need to, turning your toes out as far as you need to, and sitting back into a squat. So here I'm holding this little teeny table. This is not going to work for back pain people. You want something super, super stable. So hooking underneath the couch, squatting in a door and holding the door frame, something that's going to really hold your weight up. And you want to be really close, because if you're too far, you create flexion here. You don't want rounding of the trunk. And so what I'm doing here is the same thing in the quadruped squat. I'm dropping my glutes into this really deep squat. I'm saying, hips, be mobile, be nice and mobile. Allow me some mobility while I give you trunk stability. And the way you're giving your trunk stability here in this goblet squat is you're keeping the trunk upright, the neck long, chin tucked, the breath nice and relaxed, no rounding, no collapsing, trunk nice and stable, and inhales, exhales, nice and slow and controlled. And so you can kind of shimmy around here, or you can just kind of hold here. No need to go up and down. This is just kind of a held position. But what you're telling your brain again is, I'm giving you the safety here. I'm nice and safe and supported here. Allow my hips to be free and mobile. Pairing trunk stability with hip mobility. Cool. All right. So those are my favorite drills. Back pain happens for lots of different reasons. We identified a few of them, but if you then factor in emotional, psychological, stress-related, economical factors, other life factors, those all can influence whether somebody feels safe, whether they feel strong, whether they feel resilient, or whether they feel threat or weakness. And those can all be a factor as well in the experience of low back pain. If nothing works, none of those fancy drills that we learn, none of those drills that I showed you, then what's most important is really finding things that people can do where they can move that feels good. And it doesn't even have to involve the low back or the lower limb. If they can move the upper limb in a way that feels good, that makes them feel strong, then that's where they start. Whatever movement feels good is going to have a positive effect on the nervous system, because when we move without pain, without sense of threat, we also can have effects on other areas of the body where we're experiencing pain. We can decrease pain in other areas. The drills we looked at allow for gentle, low threat movement that can reinforce safety and decrease pain. And that's what I would encourage you to find. Find movements that decrease pain, but increase the sense of safety. And that's usually stuff that's done a little close to the ground. When people have less pain, they typically want to move a little bit more. And when they can move more, they have less pain. And so whatever movements do that for them, whatever movements cause less pain, are going to have a positive effect on the low back. So that is my spiel for low back pain and movement drills for low back pain. I've used those drills by phone with people. I'm like, people know about my low back pain story. And so I've had several people even just phone call and say, I've had a flare up of sciatica, flare up of low back pain. What should I do? And using just a few of those drills can get people out of flare-ups. I'm not saying they're miracles. They weren't miracles for me. There are some situations where surgery is necessary, but discs have, if it is a disc issue, discs have the capacity to heal. Mostly what we need to give the body is we need to give the body a sense of safety. And within safety, there's the possibility of healing. So I have recorded this. So I will post this so that if you came in a little late, you can take a look at the earlier stuff, and you can look at this again if you like. If you have questions for me, I am open to any questions. If not, have a lovely night.